Uh, I'll I'll be talking on the importance of. I would like to thank my speakers, the speakers before my session, especially Dr. Jitu and Dr. Vinan, to extensively cover the protein energy malnutrition, protein requirements in peritoneal dialysis. That makes my job easy. Actually, that's the best part for coming last to the class, probably. You don't have to speak much. You also don't have to know much. You can also speak less because the speakers before you have covered most of the thing. So I'm just going to give some basic talk about the protein requirements in hemodialysis patients with a few slides on pediatric population. Not much is done in the pediatric field in terms of dietary protein supplementation, to be honest. It was in 2008, the KDOK updated their guidelines, and then after that, there is nothing, no new studies, no new contribution in the field of renal nutrition in pediatric population. So most of the talk would be on adult and followed by some pediatric highlights. So, thank you. Disclaimer. The talk is based on the best information available at the time of presentation. Most of the guidelines are coming from the KDOK 2020, the Pediatric Renal Nutrition Task Force from 2019, and the Pediatric Renal Nutritional Task Force is basically again taking it from the KDOK 2008 update. The Indian Journal of Nutrition that was published in 2020 highlighted the Indian specific guidelines and the nutritional requirements for Indian population. Hemodialysis population. They are designed to provide information and assist in decision making, but it's not a sole way you decide. The talk is not to make sure that everyone follows it. It is just to use one's judgment and take a decision. They're not intended to define the standard of care or an exclusive course of management. So what is covered and what is not addressed in my talk? Protein requirement at the start of the hemodialysis, protein requirement in stable hemodialysis patients, and protein requirement in children on hemodialysis would be covered. I would not be talking about the nutritional assessment of nutritional status. A part of it was covered by Dr. Vinan in the previous talk. I'm not going to talk about protein requirements in acute kidney injury patients on HD, ICU patients on HD, because it's a separate topic on itself, and I'm not going to talk about patients on continuous form of dialysis. Okay, to start with, we all heard why protein is important, and a low protein intake and a malnutrition are associated with increased risk of death among hemodialysis patients. This is not just in hemodialysis, even peritoneal dialysis. Overall, a low protein intake, protein energy malnutrition are associated with an increased risk of death. Why do we need dietary protein? Dietary protein is need to maintain good protein turnover and to synthesize and lay down new tissues. So most important, along with the protein, is we need to have good energy intake from non-protein sources so that the amino acids don't get utilized for the energy needs. So as the previous speaker highlighted, we need to make sure that our patients, hemodialysis patients, consume about 30 to 35 kilocalories per kg per day. This would help to maintain a neutral nitrogen balance and prevent use of amino acids for energy needs. Unless amino acids are present in correct balance in an individual diet, protein utilization will be negatively affected. Also, one needs to measure the urinary losses in proteinuric end-stage kidney disease patients, especially in pediatric population. We have a lot of patients who are either FSGS or congenital nephrotic syndromes, massive proteinuria when we start them on dialysis. So we need to do the 24-hour urine quantification, periodically measure the urine protein losses and make sure we account for that when we prescribe the dietary supplementations to them. Continuing with the introduction, the nitrogen balance studies are helpful to estimate the protein requirements. I'm going to talk about a little bit of the nitrogen balance studies. We need to also factor in the residual renal function, especially for patients with chronic interstitial nephritis, or patients or pediatric population in whom we start dialysis at a very early to, especially in view of acidosis to enhance the growth. And to meet the nutritional requirements, we start dialysis even in patient, even with the good residual renal functions in them. We don't wait for them to reach a EGFR of less than 5 or less than 10 to start hemodialysis. We tend to start them early, especially to meet the nutritional requirements in them and to preserve the growth. In them, we need to factor in the residual renal functions and the nitrogen losses in the urine. So when you calculate the nitrogen balance studies, the nitrogen amount is calculated and it can be converted into the protein with a factor of 6.25. That's the conversion to obtain what is the protein requirement in them once you do the nitrogen calculation. Off late, there is a lot of food faddism, especially in adolescents, use of being vegan diets, lacto-vegetarian diets who are only milk or egg-based diets. So in them, one need to make, in order to achieve the right amount of balance of high quality protein, the targets may be 1.2 to 1.3 times higher, especially in these specific diet population. So then compared to a hemodialysis patients who consume both mixed diet. Okay, so if someone has a specific dietary needs, make sure that you account for it and you increase the protein requirements to 1.2 to 1.3 times to those what the mixed diet population consumes. This is the new thing, the plant-based meat diet. I mean, to get the probably a visual feeling of they're eating meat. Next, in terms of vegetable, we heard from the first speaker, a lot of emphasis was laid on the use of vegetable-based proteins. And yes, vegetable-based proteins are good because they help to correct the acidosis, they help to reduce the phosphorus, they help to reduce the blood pressure. In fact, they have a good sodium control with it, vegetable-based proteins. So these, other than these, it is also said that especially the soy isoflavones is known to protect inflammation in vascular endothelial cells, oxidative stress, reduce the expression of renin-angiotensin. They have a favorable effects on the decline in GFR. And again, they cause significant reduction in serum phosphate and FGF23 levels in CKD patients who are not receiving dialysis. I hope this also holds true in dialysis patients who have a good residual renal functions and in whom you want to start on an incremental dialysis. In patients whom you want to start on incremental hemodialysis, probably starting once a week dialysis and then going up to where the good residual, you try to preserve that residual renal function, and there the vegetable proteins play a major role. In fact, it is a combination. There are studies probably which I would highlight. There are studies where people are still kept on low protein diet and keto analogs in incremental dialysis population. 1/2 of our daily protein intake should be of high biological values, that is coming from the animal-based proteins. That is because we just heard about the importance of having essential amino acids and the utilization and the bioavailability of these proteins, how it has an impact. Protein energy wasting, we heard during the last lecture. I just want to highlight some few flag signs: a weight which is falling below the 85% of ideal body weight, serum albumin which is falling below 4 gram, serum prealbumin. Often we don't measure prealbumin, but centers which are doing, they often flag when the prealbumin drops to below 30 milligram per deciliter. Dry weight post-dialysis should fall between the 95th to 115th% of the median standard weight. And if it is either falling or going overboard, you need to reassess the nutrition and make sure that you adjust the dietary charts. And then SGA is the subjective global assessment. We often, every 6 months, we often do SGA scores at our center. And we have even including BMI and serum albumin into our SGA scorings. And any fall in SGA scores compared to the last 6 months, we flag our nutrition. A low pre-dialysis or a stabilized serum urea level may indicate a low intake of protein and amino acids. I mean, especially in Indian population, who are doing twice a week hemodialysis, a low pre-dialysis serum urea should not indicate. I mean, unless he doesn't have a good residual renal function, it should be taken as a low intake of proteins. A low stabilized pre-dialysis creatinine between 2 to 4.5 milligram per deciliter per DL in patients with a decreased muscle mass and a negligible residual renal function should be investigated for low dietary protein intake, metabolic acidosis, inflammation, and protein energy wasting. Again, this was highlighted in the last talk, where the low urea and the low creatinine is a sign of protein energy wasting. Coming to some of the nitrogen studies, I mean the nitrogen indices, what we follow is the protein equivalence of total nitrogen appearance, that is the PNA. PNA, or the protein catabolic rate. So what we do in hemodialysis population is we measure the rate of increase in the serum urea nitrogen, that is the blood urea nitrogen, before and between the two dialysis sessions. What we do is we take a sample just after the end of dialysis session, and we take another sample before the start of next dialysis session. So we calculate the difference in urea nitrogen appearance between these two, in between these two hemodialysis sessions. So the protein catabolic rate reflects the amount of protein that is catabolized in excess of the amount of protein that is synthesized per day. Patients must be in a neutral nitrogen balance, and when they are in a neutral nitrogen balance, the protein catabolic rate reflects the dietary protein intake. Often we want to keep a protein catabolic rate of around 1.2 to 1.4 gram per kg per day. What we call that as a normalized protein catabolic rate. We try to normalize it to the body weight. Sorry. Sometimes it's not all smooth with the protein catabolic rate. It sometimes overestimates dietary protein intake when the intake is low. For example, a person who is taking a very low dietary protein intake, who is having a dietary protein intake of less than 1 gram per kg per day, his protein catabolic rates could still be normal, or it could be still on the higher side. This is especially in a patient who is hypercatabolic. When he is hypercatabolic, patient's own muscle mass starts breaking down, and that produces that is causing for the increased nitrogen balance when measured. Similarly, protein catabolic rate fluctuates rapidly in response to daily protein intake. As we say, most of our patients do not have a strict dietary pattern. They tend to be extremely variable in their consumption, and protein catabolic rate reflects what was taken on that particular day between the two sessions of dialysis. So it is not overall, it is not a historical evidence as to how much a patient is taking, what amount of protein the patient is taking. Protein catabolic rate normalized to body weight sometimes may be misleading in obese patients, malnourished patients, or in edematous patients. So what we need to do is we need to normalize it to the lean body weight. So what happens at the start of the hemodialysis? At the start of the hemodialysis, patients are often hypercatabolic. They have a poor nutritional intake. A part of it is secondary to a protein restricted diet. In a pre-HD population, we often restrict their diet. We keep them on a low protein diet. And because of the uremic toxins and nausea, vomiting, their nutritional status is often poor, and they are more of volume overloaded than calorie loaded. So they often have a negative calorie and nitrogen balance and are often hypercatabolic. In a stable patient who is a metabolically stable, every day about 250 grams of protein is catabolized. When I say metabolic stable, that means he should not be admitted in the last 2 weeks in the hospital. He should not have any ongoing infection. He should not be on any immunosuppressions, or his blood sugar should be well controlled. So there are some parameters which define what is metabolically stable. In them, 250 grams of protein is often catabolized every day. Each session of hemodialysis tends to cost about 6 to 10 grams of amino acid losses. When it comes to in the hemodiafiltration and CVVHD, there is loss about 0.2 gram of amino acids per liter of filtrate, giving a total loss of 10 to 15 gram of amino acids during hemodiafiltration or CVVHD. Okay. So that's the reason we need to add these additional 5 to 10 gram per day of protein loss has to be added when the patient is on dialysis. Compared to a non-dialysis population, we add an additional 5 to 10 gram of protein per day as the requirement to account for the losses lost in dialysis. Just to note an example, what you can do when a patient is starting on dialysis and is severely malnourished at the start, there are a few things which we can correct while starting him on a hemodialysis. We can correct the anorexia part. We have to optimize his dialysis dose, make sure that his KT/V is more than 1.2. Eliminate some of the offending drugs which might cause loss of appetite, constipation, nausea, vomiting. Provide high calorie diet to ensure proper utilization of protein. One of the example is to use sabudana, which gives about 340 kilocalories per 100 grams. Encourage protein to take preparations of egg white. Egg white has a very low phosphorus compared to a protein ratio. So encourage your patients to go on egg white, especially low phosphorus, high protein, and then to high biological value protein. So encourage your patients to go on egg white, paneer, and tofu. Encourage to intake of a special renal specific oral nutrition supplement thrice daily. I'm going to talk about the supplements. Introduce intradialytic amino acid infusion on dialysis session. This is only if your patients are on a catabolic state at the start of the dialysis. Lipid emulsions can also be used, especially in CVHDF patients and in patients who are in ICU when you're starting on their hemodialysis. What does KDOKI 2020 say? This is in patients with stable maintenance hemodialysis patients. In adults on CKD stage 5D on maintenance hemodialysis, they recommend a protein intake of 1 to 1.2 gram per kg body weight. 1.2 gram for often the higher end is for the diabetics or in patients who are catabolic at the initial stage. In adults with diabetes and with a risk of hyper or hypoglycemia, higher levels of dietary protein intakes is needed to consider to maintain a glycemic control. A protein intake of 1.2 to 1.3 gram per kg body weight per day to manage protein catabolism and loss of protein in dialysis is recommended. Patients with low protein catabolic rate should receive nutritional counseling on a monthly basis to help them maintain a minimum protein catabolic rate of 1.2 gram per kg. Adjustment in the dialysis need to be done to have a KT/V of more than 1.2, and this can also improve the protein catabolic rate. Under dialysis, inadequate dialysis, often we see that appetite gets suppressed, and the uremic toxins further result in a hypercatabolic state, as explained in the initial talks. Considering the protein supplements, yes, we need protein supplements are needed in these patients, considering the increased losses during the dialysis. Include 2 cereals in one meal, for example, a rice and wheat to improve protein quality, and the ratio of the cereal to protein to pulse protein should be around 4:1. 1 gram of protein contains about 13 to 15 milligram of phosphates when it comes to pulse protein. So the bioavailability of the phosphorus from plant-derived food is relatively low. It is usually about 50%, and that from the animal protein is about 80%. That is one of the main reasons why plant protein is preferred over animal protein because of the low bioavailability of phosphorus. Patients with stable blood pressure should be advised to eat high protein food, especially during the dialysis, such as the egg whites during dialysis, to prevent protein catabolism and make sure it makes up for the losses during dialysis. Protein snack should be taken anytime after half an hour of initiation of dialysis. This was a Cochrane review published in 2020. Especially in hemodialysis patients, it was found that this was a meta-analysis of 22 trials and a big population, 1,300 dialysis population, and it was found that especially in hemodialysis patients compared to PD patients, especially in hemodialysis patients, additional oral protein-based nutritional supplementations was beneficial in terms of maintaining serum albumin, maintaining serum prealbumin, and having good mid-arm muscle circumference. So the addition of oral protein-based nutritional supplementation is especially beneficial in hemodialysis population compared to peritoneal dialysis population, probably because they are a little bit catabolic, and often the protein compensates for the calorie deficiency in hemodialysis population, whereas in PD population, the fluid calories accounts make sure that the protein doesn't get substituted for calories in them. This is an example of how the food pyramid from the, in the Indian scenario looks like. This was published in the Indian Journal of Nephrology 2020, which state that the bottom half of the pyramid, it should be universal. All patients on hemodialysis should at least go for these things. This is the basic requirement to maintain a good carbohydrate and protein requirement. I'm not going to read each one of them. In the level 2, it talks about patients who are fluid restricted. They need to be on this so that they get a very thick concentrate. For example, a curd, rajma, they need to make based on the fluid restriction, they need to concentrate the protein. The pyramid 3, at the level 3, it talks about basically a diet which has to be consumed 2 to 3 times, especially on the day of dialysis when there is additional losses, especially the fish, chicken, the animal-based protein. Level 4, 5 talks about potassium, phosphorus, low potassium, low phosphorus, and the 6th about the oil. So basically the first level 1, level 2, level 3 of the pyramid, from the bottom of the pyramid, talks about the protein requirements and how do we mix and match, especially on the day of dialysis, going for animal-based protein. Something interesting coming up in the nutrition is the study from Thailand, which probably would be published by the end of next year, with the role of ketone analogs in hemodialysis patients, and they are testing ketone analogs with a low protein diet in patients with incremental dialysis. It is yet to be completed and eagerly waiting for the results. In terms of use of keto acid supplements in dialysis patients, the Chinese population had, the Chinese authors had tried it and they found no benefit of use of keto acids in hemodialysis population. They said that even the control arm they did not achieve any greater benefits in terms of inflammatory parameters or higher essential amino acid to non-essential amino acid. Basically, they said that keto analogs was of no benefit in hemodialysis population. But another Chinese population, they tried keto analogs in difficult to treat hyperphosphatemia patients on hemodialysis. In hemodialysis patients with a very high phosphorus load, and you're not able to do nocturnal dialysis, in them what they tried was to put them on a low protein diet and to put them on keto analogs to control the phosphorus hyperphosphatemia, and they found it to be beneficial. So that's what I said at the start of my talk. Each patient has to be balanced and then needs a specific nutritional guidelines, and there are no generalized guidelines. So in case if your patient is high on phosphorus, you may have to go on a low protein diet with keto analogs. That's what the Chinese study said. Coming specifically for children, a little experience on what I had during my pediatric nephrology training was in the developed world, they were very strict when before taking patients on transplant. They ensured that they met the ideal body weight criteria on dialysis before they could be transplanted. Unless they did not achieve their target weight, they were never transplanted, even though they had a live donor or even they were very high up in the cadaver list. They ensured that dialysis patients reach their target weight before going in for transplant. And this they achieved by putting either older kids were put on nasojejunal tube and younger kids were put on PEG, that is the percutaneous enterogastric feeding. And overnight feeding was the norm for patients on both PD as well as in hemodialysis. Overnight feeds were the norm. So basically, I'm not going to talk about the protein energy wasting. It has been already done. One thing, the initial prescription of energy intake in children should approximate that of a healthy children of the same chronological age. To promote optimal growth in those with suboptimal weight gain and linear growth, energy intake should be adjusted towards the higher end of the suggested dietary intake. So make sure you meet the enough energy requirements. Most of the kids are active, they are growing, so you need to tend to keep up with that and by providing enough calories to it. The protein requirement is the amount of protein needed for the growth to balance the loss of nitrogen from the body and in individuals maintaining S. So you need to provide for the growth as well as to the nitrogen losses. For children with poor growth, the reference for what you need to do is whether you follow the suggested dietary intake. You need to follow the suggested dietary intake for the height age. What do you mean by height age beats? You basically plot them on a growth curve. Often we know our the CKD patients are stunted, so you have to match what is their height age. For if he may be a 10-year-old guy, but his height age may be that of a 7-year-old. So you need to match that, and you need to put them on a suggested dietary intake for his height age. That is something we need to be mindful. In children with chronic kidney disease stage 5D, it is suggested that dietary protein intake to be maintained at 100% of the dietary reference intake for ideal body weight, plus an allowance for dialytic protein and amino acid losses in the dialysis. For patients on PD, that it is universal, it is 0.5 to 0.3 gram per kg, and for hemodialysis, it is 0.1 gram per kg per day. For children on intensified dialysis or hemodiafiltration, we often keep them on an unrestricted diet because you're not bothered about the hyperkalemia or the hyperphosphatemia in them, especially who are on nocturnal HD or on hemodiafiltration. In children with persistently high blood urea levels, protein intake may be adjusted towards the lower end of the suggested dietary intake after excluding the causes for high blood urea levels. Do not use soya infant formulas under 12 months of age. This is basically because they have phytoestrogens, and although they are very popular among the developed worlds, up to 25% of the food supplements have soya formulas in them. This is a simple, this is what I just suggested. Among patients with CKD stage 5D, try to meet 100% of the dietary recommended intake. This is an Indian chart. I'm not going through this. This is there in the Indian Journal of Nephrology 2020. For the age, what is the protein requirement and what is the calorie requirement? I'm just put up the protein requirement chart for each, for the sex as well as the age of the child. What we need to realize is there is an additional intake of 0.4 gram per kg per day based on the age of the child. The younger the child, you need to go up on the protein intake other than the dietary requirement to meet for the amino acid losses in the dialysis. This is just a repeat of what we spoke in the adult population. Basically, you need to identify the possible signs of inadequate protein intake. You need to strategize to supplement protein intake. How can you increase? You may have to go for enteral, parental, as well as PEG feeds, overnight feeds. This is the phosphorus to protein ratio in various food supplements. What we see is egg has a very low phosphorus to protein ratio, and that's the reason egg whites are preferred. And they are also low on cholesterol when you eat an egg white. So to summarize, basically the normalized protein catabolic ratio may be underestimated when not accounting for the renal urea clearance. Factor in the urinary losses in proteinuric patients on HD, especially the protein losses. Plant-based protein have advantage of addressing hyperphosphatemia, metabolic acidosis, and hypertension, but 1/2 of the daily protein intake should be of high biological value. Patients who do not have adequate dietary protein intake should receive a dietary counseling and education, ensure adequacy of the HD. Oral protein supplementation in patients are not able to achieve required nutritional targets. You can give on the day of dialysis or on dialysis day also, especially if they are deficient. Some of the areas of research are low protein diet and keto analogs in preserving residual renal function among adults on HD. Plant-based meat diet, that is the vegan meat, nitrogen balance and long-term outcomes among hemodialysis patients, and protein requirement among patients on hemodialysis, high flux, and daily nocturnal HD. Thank you for the patient hearing.